So first of all, there is a slight change in the speakers' orders because some speakers have to go to the other sessions also. So Dr. Parag Shah will present tele-ROP screening. From because we.
So my name is Aksha. I'm a retina consultant working at Arvind Eye Hospital, Coimbatore, and I have a special interest in pediatric retinal disorders like retinopathy of prematurity and retinoblastoma. So I thank the chairpersons for pushing my talk first because I have another session to attend. So I'll be talking on the outcome of telescreening for ROP in rural South India, the Arvind experience. So we know all the magnitude of ROP, and according to this diagram given by the WHO, Born Too Soon, India has the highest number of preterm deliveries in the entire world. Neonatal care units, which were usually restricted to the urban areas, but from 2005, the government of India, under the National Health Mission, planned to open NICUs, what they call as SNCUs, special newborn care units, in every district hospital. And currently, more than 600 government SNCUs are operational in the country. Apart from the government SNCUs, we know that every major district headquarters city has around 5 to 15 private NICUs, and that is the number of NICUs which are present. And because of this improvement in neonatal care, many preterm babies are surviving even in these rural areas. So this has led to the increase in the incidence of ROP even in the rural area. The ground reality is that the awareness of ROP is low, especially amongst the pediatricians. Although trained ROP screening experts are available in urban cities, they are non-existent in rural areas. And thus there is a large lacking of providing ROP screening services in these areas. So that is where our ROPE SOS project came, which is a telescreening project for retinopathy of prematurity. So the ROPE SOS, which is Retinopathy of Prematurity Eradication Save Our Sight, was funded by Mr. Subrato Bagchi and a grant from the USAID. So the aim of the project was to screen 2,000 babies per year by doing ROP screening in underserved and rural areas where there was no ROP screening being done currently. And the team consists of 2 managers, 2 trained technicians, 1 mid-level ophthalmic assistant, and 1 driver. So no physicians or no doctors, only the technicians. And the target was to cover the NICUs situated in 9 districts of Tamil Nadu and Kerala. So the infrastructure needed was first the image capturing device, so that was the RedCam shuttle. And you can see this is a RedCam 3, this is a desktop based, which is in the clinic. RedCam shuttle is a laptop based, and it's more mobile friendly, so it can be moved from one place to the other. And so we had to do the training of the technicians, so it was in 2 phases. The phase 1 was on the RedCam imaging practice kit, which is a sort of a mannequin head, which is provided by the manufacturer, and they can take the images on this. And once they are good at it, then the phase 2 is the imaging of the actual babies in the OPD under the care of the ROP expert. And once they are trained, then they are set out, and this is a special van which we had procured to carry the team along with the camera. And this we had modified it to make a ramp and a sort of a vault that could be, secure enough for the RedCam to be carried from village to village. So it was a customized thing for to carry the RedCam machine. And of course, for the treatment part, we had a diode laser also under this funding, and the diode laser machine we could carry also in the van. And the van has even the facility to do even the laser. There was a small bed inside the van where we can actually do lasers, and has a power facility with inverter. So next comes the image transmission. How do we transmit the images from the rural to the base hospital? So what we had, the Arvind Eye Hospital already has an existing strong Arvind diabetic retinopathy software, the address software. So we modified it a little bit for ROP. And the connectivity, 3G and the 4G connection are available that we utilize for transmitting the images. And the central servers of this modified address software was installed at Coimbatore Arvind. So this is how the address software, the front page looks. So this is the Arvind diabetic retinopathy screening software. But you can see we have modified for ROP, where you can see the maternal risk factors, the neonatal risk factors. And once the images are uploaded, this is how the expert will see in the base hospital. So we first targeted a radius of 200 kilometers from Coimbatore. So this is the area in the Tamil Nadu side, and that's the area in the Kerala side. And later on, we did again add 3 more districts of Dharmapuri, Krishnagiri, and Hosur, which go outside the 200 kilometer diameter. And currently, we are covering 53 NICUs per week in all these district hospitals. So we're catering a population of around 50 million, a geographic area covering around 47,000 square kilometers, and we're covering 12 districts actively right now. So the project started from August 2015 and to June 2017. We had screened 7,299 babies, out of which around 4,000 were new and 3,000 were review cases. Any stage of ROP was seen in 1,431, and out of these, 111 were identified as a severe form of ROP in a vision threatening and were treated successfully. So apart from subjecting only for the fundus imaging, we then modified later on, let's include anterior segmenting imaging also. So that will be a universal eye care for the newborn. And with that, we could detect, of course, retinal hemorrhages is in the posterior segment, which were not related to ROP, which were also picked up. But we could pick up 10 cases of congenital cataracts, which were successfully treated, 1 case of strabismus, and even 1 case of retinoblastoma. Now coming to the awareness amongst the mothers and the attenders, so we made these customized posters which are multicolored information, half in English and half in the regional language, Tamil and in Malayalam, and they were displayed in this NICUs in all these district hospitals, all the hospitals we were covering. Apart from that, we made these handouts, the brochures, which we were giving to all the cases which had active ROP, telling them the necessity to come back for a follow-up and the importance of coming back. And this also we had in English and in both the regional languages. So another part of the program was to create CME programs, create the awareness amongst the NICU staffs. So every 6 weeks, we created ROP awareness, and we stressed on the importance of initiation of screening, and we also stressed the importance of prevention of the disease, where a good neonatal practice, where a controlled oxygen can actually bring down the rates of ROP, and that is also was stressed. And we had 11 CME programs, out of which 711 NICU staffs were sensitized on ROP. So the impact was that more parents would demand eye evaluation for the newborn, especially preterm. More health providers will refer premature babies on time, and more ophthalmologists will get trained in ROP screening and management due to the increased referrals and demand. So like I said, initially we started 200 kilometers in Coimbatore and Kerala, but then things got popular, and another NICs also started, we also want to join. So then we added a place called Malappuram in Kerala, and then we went to Dharmapuri, Krishnagiri, and Hosur, the government hospitals, and we even go to Dindigul. So now it was 200 kilometers, now we are giving a radius of around 300 kilometers in the Tamil Nadu side. And from August, we could procure 1 more REDCAM and 1 more team, and with the lessons learned, we went for a smaller van, and which could carry the REDCAM easily, and this is the one with the shock absorbers below this, so that it does not damage. So without the volt, with the shock absorbers, it has the same impact of, but at a lower cost. So in summary, early identification via telescreening prevents needless blindness for ROP, avoids visit of ophthalmologist unless indicated, increases awareness amongst all neonatal staff, and with the lack of specialized ophthalmologists, telescreening could be the only option in providing ROP screening services in the rural area. So next I'm going to show the videos of the screening project. Yeah. So you can see the REDCAM being taken by these trained technicians, the MLOPs, and the managers, and they can be easily rolled over on this ramp. And it's a fixed day for every city. And this was in Tirupur, which every Monday in the Tirupur General Hospital, GH, NIS SNCU, the van team goes. And now the patient details are entered in the REDCAM by the technician. The topical anesthetic drops are put. After putting the speculum and the gonio gel, the REDCAM images are taken. And then they are saved and they are uploaded to a different laptop which has the address software, and from there it is uploaded to the server. And this is in the base hospital where the images can be seen. And even if the grader is not in the base hospital, even with a simple smartphone, Android, we can see the images and we can report them. So the reporting is done immediately, and when she press send report, it goes back to the base hospital where the team is with the printer, and this is how the printout comes, and immediately the patient is counseled. So it's a live reporting which is going on, and the turnaround time is around 10 to 12 minutes for each baby. So that saves the time of the patient coming to the hospital, and then it's done. And this is with the phone report. So thank you so much.
I have a few queries. What is the frequency of visit to each center? Then where are the children followed up? You said, we call the children for follow-up.
Yes. So
thirdly, how are they taken for treatment? Any of those who require treatment, right, how are they taken up for treatment?
So your first question, madam, it's gone. Every Monday, the team has to go to the same NICU and do the screening. Regarding your third part, follow-up, yeah. So follow-up, most of them will have lesser stage of ROP or just immature vessels. They don't require a follow-up by our ophthalmologist. So we tell them to come back a week or 2 weeks or 3 weeks, according to the severity, to the same place where the van comes in the next week, and we do that. And the third part regarding the treatment, if the child is stable enough to travel to the hospital, then the parents will get the child to the hospital, and we do the laser or whatever treatment is required at the hospital. However, if they are sick and they cannot be transported, the pediatrician says we cannot send the child, then the doctor goes out within 72 hours there with the laser and does the laser on site there.
Thank you, Dr. Parag. I think
Thank
we
you.
move on to the next presentation by Dr. Mukesh Taneja about how to do a remote examination using a drone slit lamp. Yeah.
Good afternoon, chairpersons and member in the audience. I'm Mukesh Taneja. I work as a cornea specialist at LV Prasad Eye Institute, and teleophthalmology is my special interest area. So this presentation is about the use of teleophthalmology that we are doing at LV Prasad Eye Institute for taking care of patients in the rural areas. And the people on the first slide mentioned are my collaborators who work in the same place. So telemedicine is being increasingly used for providing healthcare services worldwide, and ophthalmology is ideal for telemedicine as most of the eye pathologies are visible to inspection. So you can directly see cornea, you can see conjunctiva, and even for that matter with the ophthalmoscope you can see retina also, unlike other organs, let's say liver, kidney, which you cannot visualize other than using maybe a CT scan or ultrasound. So that's an advantage that we have in ophthalmology. Telemedicine is basically of two types. One is the offline, store and forward. That is what generally you would see when you're taking care of the diabetic retinopathy, where you shoot a photograph of the fundus and then send it across to the main center where it is read by the specialist and a report is generated and is sent back. Online systems are very few. They are used in medicine like in ECG, Holter monitoring, but they are not very, very prevalent. So we have developed a robotic slit lamp system for teleophthalmology in collaboration with Bascom Palmer Eye Institute in US, whereby an ophthalmologist can remotely control a slit lamp. Across distances, the patients from remote areas can have access to global eye care experts. What we have done is we have just taken a ordinary upper somme slit lamp, which has been robotized by using precision stepper and servo motors, and all the slit lamp functions have been robotized, such as magnification, illumination, XYZ movements, angle change, slit height, and everything. Even we have added a digital caliper to this. So this is how it looks like. The patient on your left side is sitting across 330 kilometers in a rural setting. That is what Palwancha, about 330 kilometers from Hyderabad, whereas I am sitting in Car Campus, Hyderabad, and can see the patient. These are the internal components of the slit lamp, which have been modified by using the motors, and this is how the interface looks like. You can have the images on a desktop, on a laptop, or a tablet, or for that matter, smartphone. If you use the prismatic glasses, then you get a 3D image, which is a USP of our system. I believe most of you would be familiar with the LVPI pyramid model, which we follow at our center. We have an Apex center at Hyderabad, which is a tertiary care center. We have 3 more tertiary care centers at Vizag, Bhubaneswar, and Vijayawada. We have 17 secondary centers which are at a town level, cater to the population of about 5 lakh people. And then we have vision centers which are in rural areas, catering to the population of about 50,000. Then we have vision guardians which go door to door in villages. So at present we have 8 such devices. 2 more actually have been added just 2 days before, so we now have 10. These are the locations which you can see. So primarily, these are in Telangana and Andhra Pradesh. 2 have been added in Bhubaneswar, and there is 1 in Maharashtra also. So this is how the system works. So the patient could be sitting anywhere, like, and I am sitting here at
yeah, Srinivas, now we can hear
Hyderabad, and I can control this slit lamp from my laptop, can have the images on my laptop, can talk to the patient. So this is an examination which is going on in Hyderabad vis-a-vis Paloncha.
Okay, Srinivas.
You do not need a person to monitor or handle the slit lamp. It can be handled remotely by the laptop or a smartphone also. So the same images you can have on a smartphone, and so these are images of a same eye. You see 2 images, they are of the same eye. If you use a prismatic glass, then you see, and they fuse into one, and you see a 3D image of a one eye. And if you use this view box, then you can also get a 3D image. So these are few case studies. So this girl was a 7-year-old girl who had an anterior corneal opacity following a case of following fungal keratitis. So I did a DALK for her, which was done at Hyderabad. The patient is from Paloncha. The patient has visited Hyderabad only on 3 occasions. That is, 1 for pre-op visit, then for the surgery, and then later for suture removal. Rest of all the follow-ups have been done on a slit lamp, whereby the patient visits the Paloncha center and I see the patient from Hyderabad. This is another case which I have done a slit. This was the first time a slit was done in a rural setting, so this was covered by the local media. Again, this patient was seen by me in the slit lamp when I was in Hyderabad. So when I visited Paloncha, we did the surgery in Paloncha. Again, the patient has never visited Hyderabad. All the follow-ups and surgery were done at Paloncha. This was a patient which was shown to me by we have a general ophthalmologist who manages the secondary centers. So he showed me this case and he thought probably this is a fungal keratitis. But when I saw the patient and on the slit lamp on my laptop and talked to the patient gave a history of a hot burning oil getting into her eyes while she was cooking. So this was a case of a thermal burn. So I gave a second opinion to the doctor that this patient needs a tarsorrhaphy and amniotic membrane, which was then done by him. So the patient never had to visit us for a second opinion, and this was done at the same center. We routinely keep the records of all these patients. So roughly we have, in the past 3.5 months, we have seen about 410 patients. Approximately we see about 3 to 4 patients every day. This is from a different center. Yes, there are challenges, and mainly they include internet connection and the bandwidth. We need a minimum of a very good internet connection. A minimum of 10 Mbps is required for a good video upload. Yes, there are weather-related breakdowns also. In some centers, the temperature goes as high as 50 degrees centigrade in summers, which has a problem with the cameras. Sourcing of the parts, most of the parts which we use for these slit lamps are imported and not readily available in India. In addition to this slit lamp, we now also have a iSmart system. It's our EMR, or electronic medical record system, which have been loaded on our tablets, and these tablets are now provided in each vision centers. Vision centers are managed by vision technicians. These are local people who have trained for 1 year at our main center and then put back in the community. They can do a refraction, they can see a patient on slit lamp, but they are not able to make a diagnosis. So what they do is they take a photograph and then they connect with the Skype with the secondary center doctors, and now we also have a central command center at Car Campus, Hyderabad, where this photograph is loaded and we can have access to the AMR at a computer in the main center. And like this patient had a nodular episcleritis, so we referred the patient to the nearest secondary center. This patient had a subconjunctival hemorrhage, so we just gave him some lubricating drops. The patient did not have to travel to the higher center. So this is how it functions. The doctor sitting at the command center in Hyderabad is able to talk to the patient, and he also has access to the photographs which are uploaded on the EMR center, and a teleconsult is done then and there. If there is something significant, then the patient is referred to the nearest secondary center or the tertiary center, or something as simple as a subconjunctival hemorrhage is managed then and there.
కంట్లో చిన్న నలక లాంటి అలా పడింది, ఏదైతే ఐరన్ పార్టికల్ అది కట్ చేశారో మీరు, అది పడింది అన్నమాట, నల్లగుడ్డు మీద ఉంది. సో అది తీయాల్సి ఉంటుంది. సో దానికి మీరు ఒకసారి మన దగ్గరలో ఉన్న సెకండరీ సెంటర్కి
So we keep a daily record of all the patients which are seen. We just did a rough analysis. So in 1 month, we had approximately 58% cases were of cornea, about 4% of uveitis, and about 5% were of plasty among all the teleconsults. So we are more or less, we have covered all our centers across the LVPI network. Mainly it is the iSmart tablets at the vision centers and the drone slit lamps at secondary centers. We still have to cover about 8 more centers. The next step, of course, is to integrate both the anterior and the posterior segment. And to conclude, we believe that teleophthalmology is a good tool to help us take eye care to remote rural population. We are mainly using it to screen patients for eye ailments at the vision centers, to follow up on the patients in remote locations, patients who have been operated at the secondary centers or the tertiary centers. They are followed up on the ophthalmic slit lamp. And also, in difficult situations, they are used to take second opinion from the experts at the tertiary level. Thank you for your patient listening. These are our collaborators. We did get a grant from Grant Challenges for this particular project, and 5 of the 10
TP Das to the dais, the president of Vision 2020, please. Sir. Very nice presentation. I'd like to know the cost of these robotic slit lamps.
TP Das, Saraprasad Das.
So we have basically sourced the slit lamps from Appa Swami. The next generation we are making on the Zeiss. So it's the cost of the slit lamps plus the modification takes approximately.
Absolutely low.
Dr. Das? Dr. Das? We want you here. Not on the podium, on the dais. On the dais, not the podium. Dr. Mukesh, one is you said the challenge is the connectivity. I'm very sure it will be a big problem. I mean, is there any idea of calculate the cost per consultation?
The cost of consultation would be high if you keep into the, if you analyze the internet connectivity. We are spending something about 5,000 to 6,000 per month for the internet connection.
Connections, okay.
And the slit lamp per se would cost about 4 to 5 lakhs the own. So the cost would be high. There is absolutely no doubt. It's about the reachability. I do not see, I mean, the other way would be you bring the patient, you put the patient in a cab or a van and then bring him. So it's basically saving on the man hours, but as the numbers increases, then probably the cost would go down. As of now, the cost is high.
Yeah, okay. Yours.
What Mukesh said was we are using iSmart app also. So iSmart app is used being in the vision center and that drone in the secondary center. All that combined together, right now what we are doing is like the number of consultations in drone are less, but more in iSmart app. So connectivity as such is being used there. So as the number of drone increases, which we predict that over a period of time it will increase as we have the posterior segment module also attached to that. So I think that will make it more cost effective. We have not done a cost effectiveness analysis.
Okay.
So right now it's not very cost effective.
Okay. Thanks. Yeah. Thanks, Dr. Mukesh. Now I call upon Dr. Rohit Khanna to talk about the Vision Center, a center of care in remote areas. Okay. Sorry, Rohit, just a minute. Yeah, we'll have Dr. Sandeep. We just missed him. Dr. Sandeep Bhutan from Sightsavers to talk about mechanized refraction, auto refraction, all that modules. Yeah. Dr. Sandeep, your presentation is there, or? Yeah. There, huh? Okay, we'll ask some. Can one of you, some of you check on that? Yeah. Yes, doctor.
Right. Thank you, sir. I thank the organizers and the chair for giving us an opportunity to talk about this topic as such. Being in line with the whole topic of the session around how to use technology, so I've modified the topic slightly. It's around automated screening for detection of refractive errors, and because I know other speakers are talking about adults, I'm focusing on pediatric as such. And again, just a declaration that we have no personal or organizational commercial interest in any of the devices, and all the data and the technology that has been described is from public sources. We don't have direct personal kind of usability of any of these devices. So again, these are the outline of where I'm looking at. We don't have to talk about undetected refractive error and the significance of that to this audience. We already know that's a big problem and forms a major proportion of both blindness and visual impairment, not just globally, but in India also. And some figures which everybody knows, we already have an estimate around 20-25% population requiring some sort of refractive correction. But even then, saying that refractive errors can be easily diagnosed and effectively treated with spectacles is a line that requires a lot of thinking, because even though it is theoretically quite simple, it still is the largest cause that goes around. So again, focusing on a specific group, which is pediatric or childhood refractive errors, it forms a significantly more difficult problem because of the difficulty of finding children, plus the skill and other things involved. And moreover, we also know that developmental and other aspects of the refractive errors, if not treated at this age, are much more devastating as compared to adults. So the talk is looking at how refractive errors in children are looked at. We already have these figures that a huge number of children, around 90 million, are visually impaired. And during this process, it's not about refractive errors. We're also able to look at other eye diseases like allergies, infections, which although not visually impairing, but can have other implications. So looking at that, Sightsavers, the organization that I represent, we looked at childhood eye health as one of the priority areas, looking at around the big scope of this problem, which is close to 1.2 million government schools and close to 220 million students. All of these developmental aspects where this is the most vulnerable groups. Overall health status of the child is important, not just the vision. We also know that vision is going to have a large impact on the learning. Also, it gives us an opportunity looking at the health-related behavior and the overall development of the child. And that's the reason why we looked at school health as an important area. And here is where the identification of the problem that requires a technology solution comes in. The conventional approach to refractive errors is fairly simple for children. Train teachers, which is the approach that we look at, let them identify, screen the children for significant refractive errors, send in a refraction team which can do the refraction of the children who are identified or suspected, dispensing of good quality classes, monitoring compliance to classes, whether children are wearing it or not, and also looking at overall impact on their quality of life. Sounds fairly straightforward and should be simple. But when we actually went into implementation, from January to December, this is the data where we approached around 3,000 government schools across 6 districts in North India, Focus was on coverage and strengthening of existing systems because we wanted to be a scalable thing across all districts through the national programs. We also looked at using existing resources like teachers, ophthalmic assistants in the government sector, other NGO partners who were available, and also engaging with other educational departments like SSA and RBHK where possible. The numbers were amazing. We could screen close to 1.5 million children with the conventional approach, could refract 62,000. Prescription was around 16,000, and these numbers were looked at. But when we analyzed our data, we looked at these challenges that were there. The biggest challenge was coverage. This is a huge number of schools distributed across. Finding children out of school was a bigger problem. So getting enough coverage of this program was really difficult, even with screening almost for 15,000 teachers. Quality both at refraction level, screening level, dispensing level, it was another challenge that we were facing. Getting enough manpower to do good quality refractions at the site as well as dispensing was becoming a problem. Compliance both from screening to refractions, from refractions to children actually getting glasses, and children once they got glasses to wear them. Overall cost of the program, depending on logistics and others, was again an issue that we had to look at, and closing the loop for that matter, because it's not just limited to creating refractions, other ones. So again, as it's true to about everything, the rule of technology is everything that can be automated will be automated. And here again, we looked at what are the technology options that would be an ideal solution. And again, a spoiler alert that we couldn't find a solution as yet, but there were things that we looked at. Ease of use, it has to be usable by lower scale staff. It has to be highly accurate, reasonable accuracy. Speed of testing has to be there, operationally efficient. Durability and resilience, we saw some shows that very expensive equipment was being taken, but we need to look at durability. And of course, because if you're talking about scalability of refractive errors, it has to be low cost. It can't be massively expensive. So we looked at a couple of options, and this is where the whole concept of automated screeners or automated refractors came into play, which does take care of a portion of these problems, not all of them, but this is how we looked at them. So what is this concept of photo screeners or refractors? They have been around for a very long time. It essentially is a photographic instrument which take a photographic image of the eyes, red reflex, which is the principle of the Brochures test. But also there's a analysis involved which analyzes these images to look at any embryogenic factors in children. It also may detect other ocular misalignments and other sight-threatening conditions like cataracts and squints. Again, as I described, essentially it's an infrared camera which looks at the eyes and the undilated pupil, and it looks at the red reflex. It is effective in identifying anisometropias, hyperopias, but also other issues like eye misalignments, ptosis, lens opacities, and others. Also, it is highly effective in younger children where we expect the refractive errors to be difficult to detect. These are few of the devices that are commercially available. This is not an exhaustive list. There may be many others which are in development. We're explaining some of them. But some of these are available commercially and have been used extensively with a lot of studies that have shown. The first of these which came up was the MTI photo screener, which is again a digital photograph. It was a manual photo-based device, but it was used extensively in a large group of people. It had very high referral rate, very good referral rates, and high screenability rates of around 96%. Because it was used in community settings, there was a high positive predictive value of around 75 to 80%, and at that moment it was looked at as a good device to be pushed. Also, subsequent devices like iScreen, which uses high digital quality photographs with a back-end analysis where the images are sent to a proprietary analytic software and it sends back the results. It does demonstrate high levels of sensitivity and specificity in a pediatric office setting, but in a community setting, we see that the sensitivity was equal or slightly lower than non-cycloplegic retinoscopies and other autorefractors. Some more devices which have come up recently, like the PlusOptic series of devices, which have been designed for vision screening, but have been approved by the FDA as refractors. Again, when done across pediatric facilities, not in the community, it had very high effectiveness data of sensitivity and specificity in the range of 85 to 93%, and false positive and false negative rates of 9.1 and 2.7%. Looking at some of these options, these devices could be useful for younger children. Also, again, a multitude of data has been available. The pooled figures tell us that all available technologies have their advantages and disadvantages, and most data is still available from clinical settings. We're still awaiting a lot of community-based settings, and we know that some trials are already on way, I'm aware of a couple of them by Arvind and Elbasad who are already doing some of these community-based trials, and it would be really good to get those community-based data in, and also looking at the operational efficiency, because that is another challenge that happens on these things. Some other vision screening devices which are being done at research level, like the iSpy 2020, which is automated computer software, which tests the visual acuity, stereopsis, and color vision. The diopsis method, which is a VEP-based mechanism, which not only checks the vision, it also looks at optic nerve and visual cortex. The RebiScan, which is a barometer-based device. But all of these devices are more of research tools than community application, but I kept them there just to complete. So in general, we look at all photo screeners were reasonably effective for detection of high refractive errors and non-intermittent strabismus. But generally, handheld screeners underestimated hyperopia and overestimated myopia, whereas some also overestimated astigmatism. Ambient lighting conditions, which is a problem in the community, affected most of the devices, some more to the other. And also the refraction data that was obtained from them was not regarded suitable for direct prescription. It did require either cycloplegia or in most cases, subjective acceptance. But there are other considerations which are more important from a programmatic perspective, which are on these aspects. We look at cost, as Madam also asked about. If you look at scaling up, setting up, maintaining these devices, what is the cost and how will we look at scaling up? At what level can they be deployed, looking at this consideration, at community level, at primary care or service centers? Effectiveness, we need to look at the accuracy and can it give it a large amount of coverage that can be reached to provide impact. Also looking at requirement of secondary procedures, so if an optometrist or a trained vision technician is required to do the subjective, what is actually the utility going forward? And also looking at efficiency of work per unit device versus average, comprehensiveness and continuity, and of course, additional context like availability of power to recharge these devices, security of these devices, and servicing when they are taken into the field. So having said that, we definitely do not want to get in the technology trap, wherein automated systems not only amplify the efficiencies of a system, they're also likely to amplify the inefficiencies. So before we go into any such procedures, we also have to look at availability of staff to carry out subjective acceptance, linkage with good quality spectacle delivery mechanisms, ensuring high compliance rates, and monitoring value for money for these devices going in before going for scaling. Thank you.
Yeah, thanks, Dr. Sandeep. I mean, in our system, so one of the things is it's overestimation. So when you overestimate and say that you have refractive error, it's always better we screen these patients, the team which does it. In case now if you send these children to some other ophthalmologist in the local area, then we get a very negative feedback from those ophthalmologists to the children. Then you don't have anything, you have been unnecessarily referred. So that has been a big challenge. The other one is screening large number of children, because holding these devices are also very difficult. And no. Initially it's a screening. You are replacing the teacher or somebody. Next step is the examination part. Before that, some people are somehow screening happens at 100, 200 kilometers away. Then it may be better for the local ophthalmologist to see sometimes. So the other one is the fatigue of using the thing, and third is the safety of the devices, breakage. And it's also quite expensive. The cost also is a big barrier to these devices.
Sandeep, we have also used this similar thing, which I talk in my presentation anyway, and we agree with whatever you said. What we did was that after the teachers have screened, identify the children who are supposedly on their estimation not reading well the distant vision chart, use this device to screen them. But immediately do a subjective correction also. Right. Do not prescribe a class without subjective correction. Ultimately, those who agreed to subjective correction by the number given by the screener, only we prescribe, other one refer to the base hospital to examine them. That way, it will not as fast as you did, but then certainly safer compared to what Ravi is talking about.
Thank you. So that's exactly the point, that we are using a technology to look at a problem which was because screening such large volumes for a constant period was a difficulty. But we also have to understand that the continuity of that process, like a subjective refraction, good quality checks, would also we need to put in place before we think of scaling something like this. Thank you, sir.
Thank you, Mr. Sandeep Patan. I'll call upon Dr. Rohit Khanna from LVPEI to give his talk on vision centers. How a vision center should be built up in a remote area.
afternoon, everybody. I'll be talking about Vision Center, a model for care in remote rural areas. This is the campus in L.V. Prasad Institute from where we come from. And this will be the outline of the talk. I will just give you an overview of what Vision Center is, what are the different components, and how are we performing in these Vision Centers, and how is Vision Center being used as a model for universal eye health coverage. What technology has the role to play, which Mukesh already has highlighted. I will just touch on it, and what impact it has created in the network. So Mukesh briefed about this eye health pyramid model, where we have center of excellence at the top and the vision guardian at the bottom. And this is the place at community level where we have the vision centers for a population of 50,000. So what we call this one secondary center for a 500,000 population, 10 vision centers again for a 500,000, one for 50,000 each, and 100 vision guardian each for 5,000, a village vision complex. So it is more like a district model in a government setting, where 500,000 to 1 million population, and where you have vision center are equivalent to, like, you have a primary health center where you have the refraction units kept, and then vision guardians are like something like community health workers or ASHA workers, what you have in the government system. So this is what we call as a village vision complex, one secondary center, 10 vision centers, and 100 vision guardians. And these are, so 10 vision centers are all, so 10 vision centers are scattered around one secondary center, and then we have vision guardians around it, and then we have different eye care projects which are revolving around the vision centers and the secondary centers. So this gives us a very comprehensive overview of what happens in a population of 500,000, which we can really show impact over a period of 5 to 10 years. Given the problem what Sandeep also pointed out, so this is what is a bilateral problem. What we found is in a population of 50,000 people, you will have at least 5,000 people who have bilateral eye problems. And if you add unilateral to it, it will be approximately another 5,000 you can add. So almost 20-25% of people in a community will have some or the other kind of eye problem. So the need is huge there. And for this, because of that concept, a population of 50,000 will have at least 20-25% with eye problem, which is approximately 10,000 people. So over a period of time, if you can take care of eye care of these people, you will be taking care of almost everybody's eye care in the population. So based on that concept, a vision center also was developed, and which covers the 50,000 population, and which was basically used to provide spectacles, refraction, and also refer cases which are having eye problem to a higher centers. Typically we don't charge here, but there are institutes who charge for the vision center, but for us vision center is absolutely free of cost. And the key HR at the vision center is a vision technician who is 1 year trained for a basic optometry course, and also hands-on training is given to them. And these are the basic functions they performed are 3-4 hours, which is refraction, recognition of blinding and non-blinding eye conditions, and referrals, and also they do nowadays low vision and rehabilitation also. And a typical equipment of a vision center, I won't go into details of all the equipment of a vision center, and the structure of a vision center. Typically we have an area of 500 square feet where we set up a vision center. This is the outline, and typically a vision center usually sees 300 to 450 patients per month, and dispense 90 to 120. These are average I'm talking about. Some centers may have higher based on the coverage, some centers may have lower. And the cost for us is almost 800,000 rupees. The major cost is equipment, because we use a Zeiss slit lamp, but that cost can be worked around if you are using a low-end slit lamp in the vision centers. Just skip this. And there is a strict quality control monitoring at the vision centers by the clinical and the non-clinical team, which goes every month. And also one of the important success parameter of vision center is optical supply chain. So I think there is a good quality control system has to be put in place if you want to have all these systems into place, optical and clinical, as well as referral and a network with the community. Coming to the performance, these are the number of vision centers which have grown. So the first vision center we started in the year 91-92, which was in the city of Hyderabad. and subsequently there was a big gap of nearly 10 years, and then subsequently it leapfrogged from 2-3 vision centers in 4 to now, right now we have 169 vision centers across the network. This is the network where we have 169 vision centers and 17 secondary centers, and by the end of this year probably we'll reach around 200 vision centers. Coming to the performance, year by year the performance is increasing, but the number of vision centers are also increasing. So last year we saw was almost 300,000 outpatients at these vision centers. And just giving an example of how this vision center was used as a universal eye coverage in one of the area where we had vision centers for almost last 10 years. So we went back and look at how much population we have covered. We can go into the details, how did we do the calculations and all. But what we found was the overall coverage was 45% of the population. So we didn't cover, still in 10 years we have not covered the entire population. And the coverage was based on need. That means people who really require eye care. Many of them were normals. So the people who really require eye care we have covered only 39%. So in 10 years we could reach only 40% of the population in the community. Still 60% are untouched in that community. We also looked at the ability of vision technicians. Can they do, apart from refraction, can they pick up other conditions? Yes, they can pick up other conditions. What we found that the glaucoma, what they picked up was almost the sensitivity was 35%. So at least of 3 glaucoma cases, they could pick up at least 1. They were missing 2 glaucomas because they were not dilating the patients. And in retinal conditions, they used to pick 1:4. So at least they were picking 1 retinal condition. So how do we make sure that we pick up the rest 3 also, and even the glaucoma remaining 2 are not missed out? So their role comes the roles of technology, which Mukesh was talking about, and we're trying to use that. And we recently found that that is not published, but what we found that with technology, the sensitivity has improved from 35% to 70% using the technology as vision center to pick up glaucoma. We have not looked at the retinal conditions right now. The cost of vision center, what we found that this was the cost effectiveness analysis done in 3 vision centers over a period of 1 year, and we found that 3 vision center combined together could save approximately $62,000, which is like 20,000 per vision center. So if you have a vision center, in 1 year you can recover the cost of entire vision center if you take all the direct and the indirect cost incurred at the vision center. This I think I will not go in details because Mukesh has already touched about iSmart apps. So these are the technologies we are using at vision centers to reduce the gap for detecting the posterior segment diseases and also management of many other conditions which Mukesh was talking about. iSmart app, which he spoke about, non-mediatic camera, tablet-based application for door-to-door screening, and drone slit lamp. So this is drone what Mukesh has spoken about. And the iSmart app, which is a tablet-based application where the vision technician enters the data also. It's electronic data all now, and he can take a picture and also upload on that tab, which can be viewed at secondary center or at the command center in the base hospital. So these all things, functions which have added because of iSmart app, the gap between the cities and the rural areas have reduced, and with this app with this iSmart app or technology, we can do good patient care. There's a good quality control. We can sit in Hyderabad and monitor the quality of the data, what is coming in the tabs. We can also doing education of the vision center through this tab. So we always send just a minute pearl to vision center every day or a quiz kind of thing so that the vision center technicians get a stimulus to and do the quiz or take up the quiz and improve his clinical skills also. It also gives us the idea of coverage, which villages patients are coming from, and also gives the idea of how much spectacles are dispensed. So we can see everything online. So basically the idea is everything online. You sit in Hyderabad and you can monitor all these things, which you are not able to do when it was a manual system in place. So this is the initial stages when tablets were given to these vision centers and training was done. And this is the front sheet of the, and this is what the tablet, they take the picture and send to the command center. So just example of 1 month we had, this was in October 2017, where we could pick up almost 2.5% of the glaucoma cases using the teleophthalmology consultation. So almost 34 glaucomas was picked up of 1,362 consultation done. I'm sure there will be some missed also, but at least they were picking much more than what they were doing previously. And now this is Project Sangam, which is more like education for the vision technician through using the tablet-based application. And this is what the impact which have created over the past 10 years. From 98 to 2014, the prevalence has gone almost 200%. It has gone down in both the areas where we had vision center for the longest duration. I'll just skip this. So this, thanks to the team of all the vision technicians, we have almost like 150, 160 working in the field. It's all because of their efforts these are happening, and I'm standing on behalf of them and speaking for their behalf. Thank you.
Very illuminating talk, Dr. Rohit Khanna. Do you check the quality of images? Does some ophthalmologist checks upon the quality of images that are taken by them?
Yeah, because
do you check a certain percentage of those?
Yeah, so whatever image, because a person is sitting in Hyderabad in the command center. So whenever the vision technician, he says take one more image and send it. So whenever there is a bad quality, they just tell them to take another image and send it, as long as they get a readable image.
And prescriptions are sent. Anybody else?
Thanks, Dr. Rohit. In the interest of time, we'll move on to the next presentation, which is about capacity building of grassroots eye care personnel by Dr. Monica Gandhi from Shroff Charity Eye Hospital, Delhi.
Good afternoon, and thank you for the opportunity. At the outset, I would give the apologies from Dr. Umang because he's not able to come, so I will be giving the talk on his behalf. So I'll be talking about the capacity building of the grassroots eye care personnel. There is definitely an inverse care law, and it applies to our country in totality, that wherever there is a greatest need for healthcare, there is a great difficulty in accessing that healthcare and the least likely to have their healthcare needs met. The challenges are to serve the most disadvantaged because we do have inequalities due to the socioeconomic status, geography, and gender. There may be a lot of talk going on to understand what really is needed, but the true fact is that people who live in villages do have to travel a lot of distances to get a primary level of care, and even in these places there is a shortfall of the personnel who are delivering this care. So in our situation, maybe the zip code is more important than the genetic code because of the imbalanced resource allocation, limited physical access to the quality health services, and inadequate human resources for health. This is a fact which has been printed over and over again, and this is from the latest issue, which says that the doctor to population ratio is not optimal, and this ratio is even lesser when we look at the paramedics or the other allied personnel. And therefore, this desperate shortage needs to be met. We may be going ahead with technology, but there is definitely a need to meet the manpower needs as well. The health workforce inequalities are even more glaring in the highly populated states of North India, where the workforce density ratio is much below the national average. Therefore comes a need that we require empowered allied health professionals who can be the leaders of change and play a critical role in improving the reach of the health services to these underserved areas. With that in mind and a lot of help that we got from the Level Fund, we developed the Certified Ophthalmic Personnel Program, which we call the Jyotirgamya. The objective of this program is to empower the young women to have the appropriate ophthalmic knowledge, skill, and attitude. This in turn increases our work efficiency and strengthens the ophthalmic service delivery system and improves the quality of care. The focus is not only to empower them with the ophthalmic knowledge, skill, and attitude, but also to give them the computer skills, spoken English, and life skill education. So the method that we follow is that we have a designed curriculum which is divided into phases over the 2 years. There is a foundation course, a practical training, and on-the-job training. And the recruitment process is that we pick up girls from low socioeconomic background so that they can go back to their areas where they come from, and they can improve the healthcare systems over there, improve the accessibility to healthcare, and improve the availability of the eye care. So these students are inducted into the program in small batches, and there's a regular monitoring of the program by the created competency-based matrix. And we also have developed a career path for these students. So depending upon the aptitude, the young ladies are either put into the ophthalmic nursing assistant program, or the medical record assistant, vision technicians, and ophthalmic counselors. And it has made a lot of difference in their worlds because they seem to have found a purpose in life. So the way that we are able to utilize these young ladies is that right from the eye camps to the hospitals, they help us in the registration process, the vision refraction, spectacle dispensing, intraocular pressure measurement, and fitness for surgery. And because of the involvement of these young ladies, we have had the decrease in postponement rate because we are better able to pick up the preoperative diseases which can be managed before the patients are taken up for surgery. They do a wonderful job in counseling, and this is because they are from the similar background. They are able to understand the patient's needs. They are able to communicate in the language and the dialect of the patient, and that makes a lot of difference when the counseling is concerned. There are satellite hospital where we have found these workforces because of the girls which have been trained from that area. So therefore they go back to those satellite hospitals and they're able to work in good coordination with the team over there. So the impact has been that right now we are running the 13th batch. 299 students have been enrolled, of which 110 have graduated. It has been seen that after this program which has been brought in, the number of patients screened and the number of surgeries have increased. Of course, I would not say this is just because of the program, but it has made an impact on the clinical output. There have been an increase in the surgeries and the post-operative visits. There has been improvement in the quality parameters also, the vision, post-operative vision, the intraoperative time during surgery, post-operative infection rates, the OT starting time, the patient satisfaction index, and hand washing compliance. So the impact of the skilled and trained paramedics has brought about a reduced cost, but it has improved the quality and accessibility of eye care. It has empowered women and given them a lot of self-confidence. This young lady was from Mohammadi. She got trained in the program in September, and she's gone back to Mohammadi. And she says that her life has changed because of this program. She has become more confident, and her mother is elated with the transformation that she sees in her daughter. So this program has a lot of scalability, and there are too many needlessly blind. So definitely this program can help reproduce the similar kind of efficacy in the other locations as well. So we can reach out, give better outcomes, and more satisfied patients. The next phase of the program is accreditation and developing career pathways where the young ladies could become supervisors, tutors, and even have a lateral entry to nursing and optometry. The creating of replicable health training modules would be the advocacy for standardized training curriculum, engaging full-time and dedicated human resources, establishing the e-learning systems, and also networking with government and the other like-minded public and private agencies. So this is a healthcare which has become a team effort. The paradigm shift is from just being a doctor-centric approach. It is a multidisciplinary team approach which has brought about a change. And with this smiling lady who feels that she has been able to make a difference in a patient's life, I would say thank you very much for your attention.
What is the basic that you take up?
They are about 12 standard.
12. With science or any stream?
Any stream.
Any stream.
Because they are given a lot of the initial curriculum is that they are given about the eye, the various structures of the eye and how everything works, and they're given English skills also. So it does not matter whichever stream they are from.
And what does COP stands for?
Certified Ophthalmic Personnel.
Thank you.
Thank you.
Nice talk. Thank you. I'll now invite R.D. Ravindran from catching up. He'll talk on the remote screening teleophthalmology.
Yeah.
Okay.
Thank you, madam. I mean, I'm going to just share some of how we do it. You heard about the vision centers and also the drone slit lamp from LV Prasad. Something similar to that, what we do in our setup also will share it. So now, in the last, probably in the last 2 decades, our country has made great progress under the National Program for Control of Blindness. We were able to bring down the prevalence of blindness somewhere from 1.5, 1.6% to now probably about 0.5, 0.6%. But however, there are some inequalities. If you look at the rural location, there the prevalence of blindness is still higher compared to the urban locations. If you look at women, the prevalence is higher. And similarly, if they are unemployed, if the person is not married and they don't have any support, and again in this group the prevalence is still higher, and again it is much, much higher if a person is illiterate. At least the last survey shows that at least about 3 times higher in the illiterates compared to the literates. So it's not the same. Even though the prevalence has come down, we have not reached everybody. So in this situation, where most of these people are in the rural areas, illiterate, women, unemployed, they don't have any support, screening eye cams have been the major route for most of the hospitals, most of the organizations across the country to reach this population, where we try as much as possible to replicate what we do in the hospital, creating similar different stations wherein the patients are registered, examined, refracted, intraocular pressure is checked, and then after final examination they are also taken to the hospital for surgery, and some follow-up examination is done. And the protocol and processes vary from hospital to hospital, but this is what is being done today. And when we looked at these eye cams, how effective are these eye cams, then we did a study some time back, about 15 years back, to look at the reachability of these eye cams. We have done it in about 47 eye cams. Each eye cam covered about certain number of villages. From each of those camps, we picked up one village randomly and went to that village to understand how many people need eye care and how many of those people came to the eye camp. How many of them have eye problem and how many of them came to the eye camp. Then we found only about less than 7% of the people who need eye care in that population actually came to the camp. It was as high as about 15% if that selected village and where we held the camp was the same. And it can be as low as about 2 or 3% if they are very different, if it is far away from the eye camp site. And this highlighted the need for new strategies. If you have to cover everybody who need eye care, that is when we went ahead to do certain other things. One is we trained some village-based workers who will do door-to-door survey, examination, and refer the patients to the hospital. And also we also trained some of them to give presbyopic glasses. And we also looked at another option wherein we worked with the Indian Institute of Technology in Chennai to use their kiosk. We call it as N-Log. So this is one of the villages where they have a kiosk which is internet-based. It is much earlier. I'm talking about year 98, 99. So we have this is a person in that center. She is able to take a picture of the eye using a webcam. And then she will ask some leading questions to the patient, and the patient will answer the things, like what is his complaint. And once this is recorded as an audio file, and then there is an email is sent to the hospital, where a doctor, we have developed a program where the doctor will look at the email, he'll listen to the patient's complaint, he'll also see the images of the eyes taken. And based on that, again, he'll talk back. This is again recorded as an audio file and then sent back to the particular center. All happens in a matter of about 24 hours. The patient again comes back to the center and then listen to what the doctor has said. And very often we have to ask the patient to come to the hospital. We didn't have any other choice. So based on that, we found that that may not work. So we created a permanent facility with about 2 technicians covering a population of about 50,000. And one of the challenge was, how do we give a comprehensive eye examination? How do we maintain the quality of care in such a situation, the screening? So we had created an infrastructure wherein we'll be able to do a complete comprehensive eye examination. We had 2 staff. One is a technician, other one is like a coordinator. The technician is a person who is well trained, kind of an optometrist, And initially, first 2 to 3 years, we also have an eye health field worker who will go door to door, screen and send the patient. And after a period of point of time, they may not be very relevant in the setup. And initially, we also had modified some of the digital cameras for taking the picture along, using the fitting in the slit lamp, and we take a picture. They are very cost effective. And we also, this is a kind of the workflow where we do the registration by the vision center coordinator. Then the technician examines the patient, does a slit lamp examination, also checks the intraocular pressure. And earlier we had that low cost camera. Now with the regular fundus handle cameras becoming cheaper, we are also able to use them. This is a non-mediatic. Then they do a teleconsultation with the doctor, and based on the consultation, whether we give the glasses. And the initial period, we didn't have the broadband connectivity, so we have used the low cost. We have put up our own towers to connect all these centers. And then we also had developed our own electronic medical record to facilitate the whole thing. And now the doctor is able to give a prescription for the glasses or for the medicines right from the base hospital. So this is the kind of a brief video. This is one of our center, which is about 25 to 30 kilometers. Today, we started in the year 2004 with the first center. Now we have about 65 centers. And the patients pay about 20 rupees for this consultation. So the technician examines, they do the refraction. The subjective refraction is also done. All this data is entered. Whatever she does is entered into the electronic medical record, which a doctor in the base hospital will be able to see when they connect. She also checks IOP, she does the BP measurement. All of course with us, and then they have been in the hospital at least for 2 or 3 years, so they all have reasonable amount of experience. So once all is done, this is the teleconsultation part. And then the doctor will be able to choose the center, the patient, and can see all the details. After seeing that, she talks to the patient directly and also to the technician. If anything has to be done by the technician will do it. Otherwise, she'll send the prescription, which gets printed out in the vision center. And the glasses are also provided. Here again, we have a set of about 60 to 70 frames, which a patient can choose. Once they choose the frame, and that again, the details goes back to the base hospital, where they are made and sent back. Earlier, we used to have grind and fix it, but with the plastic lenses becoming more popular, we don't do it anymore. Yeah. So, and again, some of the drugs for glaucoma and post-operative medicines are also. Can you go to the next slide? Yeah. So in the last year, the 2017, the 65 centers, we have seen close to about 500,000 cases. And also this is probably the second year wherein we have seen more outpatients through the vision centers than through the camps. The camps, we do about close to 2,500 camps. Even that, the numbers we see in these vision centers are much more than that. We have given these glasses, and that many cataracts were diagnosed. The compliance for cataract and for the specialty referral is low, but for the spectacle is very high. And about 1/3 of these patients also pay for the surgery. And similar data as what Rohit showed. These are all centers. There are 42 centers which had been there for more than 5 years, and they cover a population of about 28 lakhs or 2.8 million, and we have about 11 lakh patients. The unique patients in that population, which is a coverage of about 41%. So now once the center is there for about 3 to 4 years, probably we estimate that all the patients who need eye care, which means the people who are blind, who have severe visual impairment or moderate visual impairment, all we would have covered during this period. So that's about the comprehensive eye examination part. And we also do some DR screening. We do it in the urban area. We work with some of the diabetic clinics, wherein we have put the cameras, the fundus cameras, we have put slit lamps, we have trained these technicians there. And they are all usually within the same city, wherein with this fundus cameras, they are able to take the pictures. About 4 different fields are taken, they are uploaded. Once they are uploaded, they are sent to the main hospital where they are read by one of the doctor, and the report is sent back to them immediately. So this has been working very effectively. But in the rural areas, what we have done is we have sent the cameras to the primary health centers where the patients come for collecting the medicines. And at that point of time, the patients are all screened. And again, these pictures are sent back to the main hospital where they are again seen by the doctor, graded, and sent back to the primary health center immediately. And the doctors know which are the patients who need further care by an ophthalmologist. Similarly, we just saw a ROP screening. A very well successful program is being run in Karnataka by Dr. in Narayan Nethralaya, which is covering almost the whole state for ROP screening. Similarly, we have also, the first presentation by Dr. Parag was about how we are doing it. We are covering now about 12 districts. So in a way, now, if we have to come up with some similar systems. If you normally see in the health system designing, we put a lot of emphasis on developing hospital infrastructure, especially in our country, we put a lot of emphasis on developing secondary level. But screening, finding the patients who need care, and has to happen at that level. Many of them may not be able to, even though it is some facilities are available at the district level, they may not be able to come. And having the doctors, we can make some of the diagnosis screening for some of the diseases at the community level, but if we have to cover comprehensively everything, we need some of the technologies which will go a long way in covering all the patients. And by that, we'll be able to truly give the universal coverage. Thank you.
Thank you, Dr. Ravindran, for a very illuminating and very comprehensive talk. I'll now invite Dr. Das for the final presentation. That is experience of eye care in a tribal district in Odisha.
The tribe we describe historically a social group existing before so-called civilization started in the state or a country or locality, etc. That is a description in a Webster English dictionary. There are supposedly distinct people. They are dependent on their land and their livelihood, oftentimes self-contained, sometimes self-sustained also, but unfortunately not integrated in a national society. But once upon a time, now aboriginals of Australia or tribes of India are slowly getting integrated in the mainstream. So oftentimes difficult to differentiate between a tribe and an actual person. By census of 2011, 9% or 10% of the Indian tribal population are Indians, live in India, and Orissa has got 8.14 million, which is incidentally 22.1% of the Orissa population in 2011 census. 4 districts of Orissa, which also next slide, have got a population, tribal population more than 50%. These 4 are shown here. Name will not be easy to remember, so I will not talk about the name. So it is between 55 and 57%. We worked on one particular district. That district is called Rayagada, which is also predominantly one of those 4 tribal districts, though some industry here and there, but mostly are tribal. 2 particular, this Rayagada by geographical description is a population of almost a million people, 56% tribal. Is a 454th ranking in a district of India of 640 districts. Incidentally, the female ratio is more than male ratio, so the female literacy is though less than the male literacy. 2 predominant tribes of this particular district called Rayagada are called Dongriya. Kandha means a tribe in Oriya language, and other one is called the Soria. And they either stay in the hills and they are a little away from the community. Between the 2, this particular Soria is a little more closer to the civilization than otherwise. It's not difficult to reach, but then difficult to get anything done with them because they are reluctant to they don't believe that you can do a good work for them. August 31, 2015, we established a hospital in this particular district, so-called Naxal-infected district, and we insisted that L.V. Prasad must go there. And since then, we have been working in that particular district. And when I did a third-party survey, how they are working after first 2 years, we found that good visual outcome, 90% of the people who had operated had a good vision outcome. Based on that, they have improved their daily skills or mobility or psychosocial improvement. Similarly, though L.V. Prasad by default doesn't do so-called screening or operation outside the campus, and then 80% of them came back for review because we are interested in improving the health-seeking behavior of people, and they are happy when they come to hospital as recommendation, food or waiting time, counseling, doctor's behavior, etc., etc. In this, this is not a updated data, but 2-year data shows that we had 35,000 patients examined, of which 53% were completely free, and we had roughly 3,700 surgeries, of which 86% were free. Predominantly, in this kind of situation, will be 80% or 90% will be cataract surgery. We also had opportunity to, like Sandeep was talking about, opportunity to examine 153,000 plus children in their schools through the help of 215 trained teachers, followed by our own optometrists or doctors. This is one of those programs where optometry teaching those health workers and the teachers. Then also we had an opportunity to the help of the CBM examine people, door-to-door survey of 29 panchayats, of which 71% of the people staying on those people could be examined, not 100% because of either time you visit, they are not in the town, not in the home, or they are gone some other work, or children are in the school, etc., etc. But we add the children of those areas, then become 75%, we know. Experience, based on experience with designs to write up what we are doing, and that program, that write up series we called TOAST, standing for Travel or Reside Study. I will give only a brief overview of those 4 or 5 work that we have done. TOAST 1 looked at the prevalence and causes of visual impairment among the tribal children in urban location, because there is a school in Bhubaneswar where the tribal children from these 4 states and surrounding certain other states come and study. The only tribal children can study there. This actually school is named after tribal students only, and this is just getting in press in Japos. And this shows that the people of tribal students who live in an urban area today, 60% of them have refractive error, 17% have amblyopia, and 15% have posterior segment disease, but blindness prevalence was relatively low. Obviously, they will not recruit students who are blind to the school. I will not describe all the papers because it is not possible in a shorter time. This TOAST to look at the school screening program effectiveness of the multi-stage screening, because as Sandeep was talking about, we can't examine large number in one go. How to use the school teachers in vision screening, also detect the ocular anomalies other than the refractive errors, and that we found that we had these 4 stages. Stage 1 by the school teachers in the school, stage 2 photo refraction, like Sandeep was talking about, done by the optometrist or the refractive person. Then comprehensive ophthalmic examination on those required to in a rural hospital in Rayagada, and then those are still further required in pediatric surgery, which you cannot do in Rayagada like place because of anesthesia problem to being to Bhubaneswar. So we found that teachers are 80% time sensitive and 53% specific. Unfortunately, negative predictive value are 26%. But we confirmed in this paper that detection of ocular anomaly beyond refractive error should be part of the school screening just for refractive error and giving pair of glasses. In TOAST 3, like Sandeep was talking about, we also performance of the SPART screener or the vision screener. We particularly use a well-trained machine, and we do the photo screening of all the people, required people, and those who have subjective correction only get the pair of glasses by optometrist, otherwise they get examined. We found that the photo screener utility in adults is poor regression analysis, poor regression, and then very good relations in children. We said that children only should use this particular device for screening purpose, and oftentimes can be used for in a particular range which your paper describes, can be actually prescribe glasses, but not without subjective correction. The TOS 4 talks about the accuracy and utility of photorefraction actually in a school screening, but that was in a hospital-based situation, controlled environment. In school screening, this was submitted to IJO, and then this fellow says that there is a good correlation between good correlation between what you see and what you prescribe. So it is useful for the children to use, but this is all proven many times before, but we want to reprove it in our own setup. TOS 5 talks about the comparison of prevalence and causes of visual impairment among tribal children in native location, like the Rayagada district example, or in an urban school like in Bhubaneswar, and this is in still in preparation. It says that the urban people have a worse visual impairment compared to the children sitting in the native area. But in a blindness severe impairment, there is none. Most of all is related to more reading or less ambient light reading, less amount of outdoor activities in a city like Bhubaneswar compared to the students in the villages. The final panel paper is in vitamin D deficiency. Government of Odisha has a constant denial that there is no nutritional deficiency in particular district, though we thought there are, because we found out actually there are. And in this paper in preparation, it says that there are different forms of different stages of vitamin VAD, where their congenital neurosis was highest 2.7%, followed by battered spot, corneal scar, and night blindness. And this is one example of we don't have example of a child who had in paper we had. There are few children who had a typical vitamin A deficiency with a sparse hair and thick skin and a lot of other things. So these are our effort in Rayagada study, but there are paper 7, paper 8 is not even thought, so we will not talk about that. Thank you very much for the opportunity.
Thanks, Dr. Das, for wonderfully covering the children in that tribal area. So not only you have set up a hospital to take care of the population there, but also have tried to understand what are the prevailing problems, and so that proper solutions can be also be framed. So in the interest of the time, I just hand it over to Madam for the closing remarks.
Thank you, Dr. Ravindran. As discussed, though we know that the prevalence of blindness in India is slowly coming down with the efforts of government and NGOs, but still, as we know, India is a diverse country, and there are still certain pockets, especially because of the rural and urban proportion availability of ophthalmic man doctors and paramedical staff, and some areas, so we still have those pockets to be covered. And the technology that has been developing now, if it can, what will be the use of this technology? This aspect was very well covered in these talks. Telescreening being the sheet anchor, but still I feel that telescreening is a good example for NGOs and for private persons, wherever government has tried. Government has tried only in one state, Tripura, though it's doing okay, but it has not been reproduced in other states. That is again a question of operational research or some kind of research paper. In principle, it's very good. I don't know why it doesn't work much in government. Of course, the drone idea is good if it can be brought down, the cost can be brought down. That is a very good idea. And of course, the connectivity problem is taken care of. Tribal districts, we need more such hospitals in the tribal districts, sir. And I hope that other people will take cue from you, and they will have they will develop certain hospitals in tribal areas. And I hope with the efforts of all of us, all the NGOs, the government set up together, and with the training programs for the ophthalmic, as we know, the ophthalmologists, of course, are very few for such a large country. So we have to give emphasis on the training program of ophthalmic assistants, or whatever we call them, paramedical staff for ophthalmology. And I think we'll have to have sessions together at the government level to revamp this training program of ophthalmic assistants, rather rename it, revamp it, because now newer technologies have come. And I think this will go a long way in providing for eye care of the country. Thank you.
Thank you, madam. Thank you. Thanks. I also thank all the participants, the delegates, and also the speakers for this wonderful session. Thank you.